Hello everyone, I am Dr. Eben Jose. I will be speaking about imaging and endovascular interventions in upper GI bleed. First, let's talk about the anatomy. This is the celiac artery, that is the main trunk, divides into the common hepatic artery, splenic artery, and the left gastric artery, which is not shown here. The common hepatic artery further divides into hepatic artery proper and the gastroduodenal artery. Hepatic artery proper further divides into the right and left hepatic artery. Now, anatomy of SMA. This is the SMA main trunk, which the first branch on the right side will be the inferior pancreatic duodenal artery, which is not shown here. Then you will have the middle colic artery, and then you will have the ileocolic right colic trunk. Further divides into the ileocolic artery and the right colic artery. Here you will have the terminal SMA. Here the jejunal branches on the left side, and below them will be the iliac branches. So, what are the indications for intervention in GI bleed, upper GI bleed? The indications are hypotension, tachycardia, transfusion requirements, hematemesis, melena, or hemophilia. There are no absolute contraindications, however, there are relative ones. They are uncorrectable coagulopathy, allergy to contrast, any active infection, or renal insufficiency, where we cannot give normal contrast. So, that time we can go for carbon dioxide angiography. Now let's talk about the embolic agents. Now these are the weapons we have to stop the upper GI bleeds. The most commonly used are coils. Then we have gel foam slurry, liquid embolics, particles, covered stents, and the last option will be vasopressin infusion. So when you come to coil, there are a lot of choices. You have the regular ones, they are little larger ones. They are 0.35 inch versus you will have micro coils. They are very thin, small ones, and they'll be deployed in micro catheters, the size of which will be 0.18 inches. Then you'll have pushable coils versus detachable. Pushable ones are you have to inject it with saline or you'll have to push it out with a wire. So here once it is once it is in the artery, you cannot pull it back. However, detachable coils are very helpful where even if you deploy, you can pull it back to an extent. You can resheath it also. Then you'll have fibered versus non-fibered. Fibered has more thrombogenic property, so it'll quickly thrombose. So whenever you are coiling an artery, you should upsize the coil size by 20%, and when it's a vein you're coiling, upsize it at least by 50%. So here you can see these are fibered coils over here, and this is coiling of an aneurysm over here. So this is a tight packing of the coils which will lead to the obliteration of the aneurysm. We can use gel foam slurry. So here you prepare gel foam slurry using the Tesserae method, where you'll cut and put gel foam in a syringe, and in the other syringe you will put contrast and saline, and you will inject into each other, and that will form a paste like consistency, that is a gel foam slurry. So this can be used whenever you need a temporary occlusion, a temporary block to the hemorrhage. However, there is a risk for reflux and even non-target embolization. So even when you do a coiling, sometimes there is no complete block or complete stasis. So that time you can put a bit of gel foam and that helps. When you come to liquid embolic agents, we have glue, and glue is also known as NBCA, N-butyl cyanoacrylate glue. So here glue is always mixed with lipidol. But why lipidol? That will give radiopacity, it will give a proper medium, a proper viscosity, and a proper rate of polymerization. So those have you mix it. You will take lipidol in one syringe and you will take NBC in another and mix into each other, and this is the final syringe which you will use for embolization. Now the ratios are pretty important. Sometimes you need a high lipidol glue ratio, that like 8 is to 1, 10 is to 1. So what is the use of this? Here you have more of lipidol and less of glue. So here the polymerization will be more slow. Hence the glue will end up going more distally into smaller vessels. So when you need types like that, when that is the need, you go for a higher lipidol glue ratio. With lower lipidol glue ratio like 1 is to 1, 1 is to 2, 1 is to 3, here the polymerization is very quick and it is suited in a very high flow system where you don't want any non-target embolization and you need quick blockage at that site where you release it. And most important thing is anything ionic, whether it's blood, saline or dirty gloves, will precipitate this glue and it will block the catheter. So always you should flush the microcatheter with dextrose or sterile water always, and never with saline before injecting the glue. Then you have particles. Particles are rarely used in GI hemorrhage, however, they are worth to know. So here particles will arrest flow quickly and usually used in end vessels. And however, the problem is there is higher risk of ischemia and compared to gel form or coils. So it is less used. Then you will have onyx. Onyx is usually used in neuro embolizations. So here, onyx is a substance that is not adherent to the vessel wall. It will occlude by filling the whole space. The mainly two densities, one is 18, the other one is 34. 18 is thinner, 34 is thicker. So here the concept is the edges will polymerize, however the center will remain liquid and it will take up a whole luminal space. So here the solvent used will be dimethyl sulfoxide. It is rarely used in upper GI bleeds. And an important thing is post-embolization with onyx, if you're going for surgery, you should warn the surgeons because onyx will spark whenever you use a cautery material. So here you can see this is a DMSO and then you will have onyx. You have to mix both and you should inject. So here we have come to covered stents, and this is very helpful when you want to maintain patency of the injured artery. So but the thing is you have to use long stable sheets to deliver the stent with good amount of precision, and always oversize the stent by around 10 to 20%. So during the procedure, the main thing is you have to engage the artery, whether it is the SMA or a celiac artery, you should hook it. It's usually with a SIM1 catheter or a Cobra. And we use a microcatheter for superselective engagement of small branches of SMA or celiac, like GDA or hepatic artery or distal splenic artery. And once you engage them, you can plan about the intervention. Sometimes you can give IV glucagon, but however we don't give it usually. So this will help in stopping the peristalsis and that will improve the image quality. And always use a higher rate of frame, 4 or more per second. And if hemorrhage is not seen, don't stop immediately. Try other views, oblique views. And if it is still not seen, wait some time, wait for 10-15 minutes and repeat the DSA because hemorrhage is usually intermittent. So once the location of hemorrhage is identified and once you are in the artery, you can plan the intervention. You can plan which micro catheter to use, micro wire, and the embolization method. You think if to use coils or an embolic agent, a stent, or a vasoconstrictor agent. And once, suppose you have taken coiling, once the coiling is done, always prefer to do hand injections and never pressure injections. And suppose you have deployed many coils, however there is more stasis to be obtained, then you can inject a small amount of gel form. That will usually help. Even if there is flow, even then wait 2-3 minutes and repeat a hand injection, and usually they would have thrombosed. And the last resort is vasopressin infusion. I myself have not seen this. So here we will place the catheter into a target artery and initiate a vasopressin infusion, and you have to repeat the DSA after 20 to 30 minutes. And once the hemorrhage is controlled, you'll have to reduce the dose by 50% and you should taper it. So now I'll show you a few cases. Here a SIM1 catheter is used and we have hooked the left gastric artery, and that is showing a pseudoaneurysm in the mid part. So here you will always have to go distal to it, and then you should start coiling distally, then at the neck and proximally. But why so? Why do you have to sandwich all these arteries? The reason is, suppose you only coil distally, so then the aneurysm will fill proximally. Suppose you only coil proximally, then the aneurysm through some or the other collaterals will fill it, and again the aneurysm will burst. So you should always block it distally at the neck and proximally also. So that same thing is done. You can see the amount of coils that is deployed, that has resulted in complete occlusion of the aneurysm. So here the GDA is ligated surgically, and at the ligation site, at the stump, the GDA is having a pseudoaneurysm. So as you can see, GDA is pretty proximal, and you have the proper hepatic artery divided into right and left. So here you would want to maintain this artery, you would want to maintain the patency. So it is better to put a covered stent over here. which was placed, and you can see the whole artery has come to near normalcy. There is good patency and there is good flow distally. So here there is another, in the common hepatic artery there is a large pseudoaneurysm. Again, a covered stent is preferred over here, which was deployed, and that shows full occlusion of the aneurysm. Here you can see this is the hepatic artery. This is divided into right and left, and in the right hepatic artery there is a small pseudoaneurysm. So here you don't go for a covered stent because it's just a branch of the right hepatic artery. So here you go distally, you put some coils, at the neck you put some coils, and proximally here you use the sandwich technique. So this is a case of SMA pseudoaneurysm. So this is the SMA, this is the SIM1 engaging the SMA, and proximal SMA, say there is a small pseudoaneurysm arising from the inferior pancreaticoduodenal artery. This is the pancreaticoduodenal artery, and there is a pseudoaneurysm arising from it. So here the best option is coiling. So here you go distal, you coil from here, then you coil at the neck, and you coil it proximally also. But the problem is the stability of the main catheter and micro catheter is an issue, because here it's 90°. So for a good stability, you would deploy a stent first, and a stent assisted coiling will be done. So good thing is it will wedge the main catheter and micro catheter, so it won't come out. Another thing is you can coil till here, till the very end you can coil, because you have a good stability, because the stent is deployed over here. So as you can see, distally it's coiled, the aneurysm is coiled, and even proximally it's coiled very tightly because a stent has been deployed. So this is the case of stent assisted coiling. So I have come to the end of my presentation. Hope you have understood all these cases. Thank you.